Welcome to Medic Life, a video podcast for EMS professionals with your host, John Newton.
It's John Newton here at Medic Life, and we're going to pick up with part 2 with our interview already in progress, and we're talking about Narcan for providers and the public, and I'm speaking with Mr. Bruce Hoffman. So enjoy, guys, and thanks for watching. Said that the big thing is oxygen, and a lot of times we do forget that. Even with all the emphasis in EMS that we've placed on that whole 94%, these folks really do need oxygen. At the same time, and I'm going to play devil's advocate, there is this argument that you kind of need to stop that process. You need to kind of, like, the toxidromes, you need to really kind of knock out the heroin or whatever this opioid is. And there is still a lot of heroin out there. Absolutely. And there's a lot of combinations of drugs. People really get inventive nowadays. Right. I'll play devil's advocate and say that while, yes, there is a need for oxygen, I still think that we need to focus on stopping this process. We need to follow our ABCs, but as soon as we can stop this process, that's what we need to do.
Right. So no, and I think that's a very valuable point. It's salient for sure. It carries weight. But again, you often see people almost, and this happens sometimes with EMS providers, where they're almost paralyzed by the maximum amount of tools that they have. It almost creates a paralyzing syndrome where they're not sure what tool to pull out of the toolbox first. And so when I step back and kind of think about when you say we need to stop the process, again, I would offer this. We know, just like you said, people are getting very creative, very inventive. So it might not just be heroin. It might be heroin plus a little fentanyl, maybe plus cocaine or plus, XYZ. You fill in the blank kind of with the material that they're gonna lace it with. And that could actually really work to the detriment of the patient if you were to actually reverse actively and competitively reverse their opioid toxidrome. And then, now we have some other laced item here that we are not sure what it is now wreaking havoc on that patient's body. So as much as I can and respect and understand, yes, we need to stop the process, there is really two sides to that story. And again, I would add, this goes back to the initial discussion and when Narcan came around. Nurses, intra-hospitally, paramedics, extra-hospitally, physicians, anesthetists, all this thing. They were giving the max dose of a reversal agent like Narcan to really get that patient fully awake, alert, and oriented. And then we started seeing another kind of nebulous concept evolve from this, which is, you're really taking this person out of a opioid-induced kind of bliss. And then certainly they were kind of getting aggravated and agitated, and that was opening up a whole other ballpark. So kind of the classic probably argument is this: do we go and reverse their opioid toxidrome only to, 5 minutes later, put them down with Versed or Valium or, some kind of other, rapid sequence induction, right? For,
the question that's coming, right? The question that's coming. The question that's coming is this. Yeah. And I'll let you finish. I didn't mean to, I did mean to cut you off, but because I'm going to let you finish. But so your opinion, wake them up or just change the respirations? That's a debate in EMS.
Yeah, and that's kind of what I'm getting at. We used to give it to the point where we were waking people up. And Narcan, in my opinion, again, is used As again, when we look at an opioid toxidrome, we can look at the signs and symptoms. Obviously, the biggest one certainly being, a hypoxia or a hypoxemia, certainly related. You have hypopnea or the shallow respirations, the bradypnea or the apnea. Those are really kind of the classic symptoms. It does say, that we want to look for altered mental status or unresponsiveness, but most of that is centered around their apneustic kind of control, which would be that cardiorespiratory center. So to me, we give it to really reverse that. Effects for their heart rate, effects on their respirations, and then certainly allowing that patient to then naturally come out of their toxidrome if they are able. But that requires evaluation and assessment from us. I think part of it is provider discretion in terms of how much work they want to put into it. Do you just want to wake this person up and let them refuse? Do you want to wake this person up and let the emergency department kind of handle them?
And that right there is a problem right there. And that's where I want to kind of interject. You say let them refuse, and that should never be an option.
Absolutely not. You're exactly right.
And we do have people that do that. There are services that allow that, and we really should not be, because simply what you were saying earlier, you give them the medication, they come around, everything's right in the world, 10, 15, 20 minutes later, they've rebounded and they're just as bad as they were before. And where's EMS?
Right.
Down the road somewhere.
Yep. No, and yeah, absolutely. I think, that same discussion, again, not to super interject, but that same discussion happens with diabetics all the time, right? We give them dextrose, and then we sign a refusal because they're competent then, and then they go back to bed or whatever they were doing. So I think a lot of this revolves around the discretion of the provider, and really being able to say, this patient requires assessment at the hospital because of XYZ reason. I would agree. There are very few reasons why patients after an ALS intervention should really be allowed to just kind of up and walk away. And I think we have to treat that with some deference.
There is an argument that can be made with the diabetic patient. You've got a competent adult that you're leaving them with, you fed them, and I get that. These patients, not so much. And, I got to say, I have always been a big fan of waking the patient up. A lot of people say, oh, well, I don't want people to puke on me. I don't want to fight with people. And I can honestly say I've never had that reaction. Part of it is how you push the medication. If you slam it home, then these people are going to wake up. They're going to jump up. They're going to puke. They're going to fight. And that's kind of what we see. Now, that's only a small percentile if you look at some of the studies of people that actually do that. But the thing is 10, 15 years ago, I did not have a problem with that.
Right.
Waking patients up. I'm still somewhat, and maybe this is a little bit of a sadistic thing, the whole, dude, if I've got to be here at 2 o'clock in the morning because you've done something that was totally stupid, then I'm going to wake you up and mess up your high. But at the same time, it's kind of like you said earlier, we talk about these combinations of things people take. Okay, so we've knocked out the opioids. What kind of crazy rage are they going to be in because of this other toxin that's in their body? And they put some toxic stuff.
Absolutely.
We talk to our students about some of these things when we teach classes, and I know you probably talk to some of your students as well. And like, it still amazes the crap out of me. And for those of you guys in the audience watching it live, or you watch it after it's posted on Friday, you guys have got to look up this thing called crocodile or crocodile, depending on how it's spelled with a K. It's like gasoline and lighter fluid and some other stuff that they just like cook up and inject in their body. And people look like cast members from The Walking Dead. It's ridiculous. And it's like, why? Why would you want to do this that it's going to happen?
Right.
So, of course, I guess the same argument could be had about probably one of the most common opioids that we talk about is heroin. And you think about the addiction level, and you see all these TV shows, you see people who it just messes up their whole life.
Absolutely. Yep.
Um,
And John, you bring up some really great points, right? So like you talk about kind of the whole emotional component of this. There are some people out there for whom it really does give them alternative chances than the predicament that they were in. And certainly we can, bend an ear to that and be very empathetic. And I think that's necessary. The other piece that I thought was very interesting that you mentioned is when you have people that are just slamming in 1, 2, 3, 4 milligrams of IV Narcan, that patient is going to come to a very brutal awakening, and they're going to bring you right into it. And part of it is kind of how we in EMS how diplomatic are we, right? Sometimes, we almost perpetuate and make it worse, getting in their face. Well, what are you doing this for? This is, again, we've been here 9 times, instead of kind of bending a little bit that empathetic ear and kind of trying to use, again, maybe I learned it, I know, in nursing school, and I did in paramedic school as well, but there are non-pharmacologic interventions that we can use in conjunction with, right, some of the medications that we carry to help de-escalate kind of the situation. And just, if I may,
so the whole purpose of this particular discussion was supposed to be about Narcan, but I think this is definitely a good segue into looking at past Narcan, or how we can actually look at different ways of maybe not going to the medication as quickly. Right. And you made a good point. You said that you were taught in nursing school, and that's the first thing you said. And you remember a little bit from paramedic school. Unfortunately, and this has been one of my biggest gripes and one of my biggest complaints is there is a psychological component that we really, as EMTs, intermediates, advanced EMTs, paramedics, right, even the first responders, we don't get a level of training for the psychology of it all.
Absolutely.
And, I raised my hand. Yeah, I've been the, 4 shifts in a row. It's 2 o'clock in the morning. Dude, seriously, you did what? Oh, and did the,
hand to the forehead salute,
Yeah, and this is like, you're a freaking idiot.
Yep.
Come on, let's go to the hospital kind of thing. And that's not appropriate. And we all get that way. It's a burnout thing. So I think, yes, we should take a step back and look at our own self and our own practice, but we should also think about some of the education, not just with identifying these patients, open the airway, here's the Narcan, there is a psychological aspect to it, whether they wake up before or after we give Narcan.
Absolutely.
How are we dealing with these people? Because, we've already had the conversation that some of these people, they wake up and they're like, let's go, man, kind of deal. And it's like, what do you do?
Absolutely. Well, a couple comments, right? So I just want to touch on one thing. We talk about, and this is what I mentioned earlier, about policy, protocol, and guidelines, right? So if we allow, let's say the scenario is an EMT-Basic walks in and says, hey, I've recognized this as an opiate toxidrome, like you say. They're hypopnic or bradypnic, or they're apneic, they're a little bradycardic, things like that. And they see the needle is still in the arm and maybe it's heroin or whatever. And so they go ahead, they want to treat it. They begin maybe some rescue breaths with some oxygen, and they use the atomizer device, and then all of a sudden now the patient comes out of their kind of CNS depressant stage, and now maybe all the toxidrome that they're experiencing might be a sympathomimetic, right, or a true anticholinergic effect, where now all of a sudden you're having their heart rate in the 200s or 180s, you're having their blood pressure, systolically 240, 230s. And now the EMT-Basic has very little control over the situation, right? And not that he's looking to have, or he or she is having control, but they've almost made a situation go from, I could have controlled this alternatively, to now I'm really walking down a pathway that I did not want to be walking down, right? So again, developing, systems where we have, and this would be great for EMT-Basic services to say, hey, you know what? Let's develop a policy that says we will carry atomizer devices, but we're always going to make sure that a paramedic is dispatched as well to that same location, especially some of the services and things like that, right? So
I hate this term, and I tell my students this all the time. I'm probably the peer that drives this conversation, but this whole stay and play, load and go, and I so totally hate that term.
Right.
But I think, yes, I think in this aspect, if we're putting this in the hands of EMTs, this needs to be we're having either a paramedic intercept, or you grab this patient, you stabilize the airway, you get the wheels rolling. If you want to go ahead and give the Narcan, that's fine. But, we're either picking a paramedic up, 5 blocks down the road, or, we're not waiting around.
Right. Yep, absolutely. And that's a very valid point. Like, we can treat this, right? This is nothing, this opioid toxidrome is really nothing shy of. We're realizing the symptoms of the opioid toxidrome. And that is something that we regularly see with patients that are bradycardic, altered mental status, unresponsive, hypopneic, bradypneic, etc. Right? And so I just want to make sure that we always provide for a safe mechanism for those that maybe do not have all the tools in the toolkit. Right. It's kind of like I heard a story recently. It wasn't in the news. This was from a personal friend of mine about a flight crew that was coming in, and they had etomidate, succinylcholine, and Versed. And this was a larger patient with a head injury. They had used etomidate and sux to rapid sequentially induce the patient for intubation. They facilitated the intubation very nicely. They chewed through all of their benzodiazepine, Versed or Valium, whatever it was, and now they have a patient who's intubated. The paralytic has worn off, as well as they have no more short-acting barbiturate or benzodiazepine, and it forced them to land the helicopter. It forced the flight to land early of its destination, and they certainly, they called in, they got resources, and went on. But that's an example of kind of thinking in terms of EMS leadership. Make sure, if we are going to give our EMT basics or lay people, volunteers, first responders, whatever you want to say, Narcan, that we adequately support them throughout the entire sequence, and not just giving them and throwing at them Narcan and saying, hey, go out and have a good time.
Thanks for watching part 2 here on Medic Life. If you missed part 1, don't forget to go back and watch that. This episode will continue on part 3 when we continue our discussion with Bruce Hoffman on a Narcan in the public and for providers. This has been another episode of Medic Life. Thanks for watching, guys.